Let's go over the warm-up. First question. A defect in the expression of the FMR1 gene is associated with what disorder? That's Fragile X syndrome. And the last question. What's the antidote for each of the following substances? So the treatment for iron toxicity is deferoxamine, which is an iron chelator. The antidote for lead poisoning include EDTA or Succimer or dimercaprol. The antidotes for cyanide toxicity are nitrites, hydroxycobalamin, or thiosulfate. The reversal agent for methemoglobin is methylene blue. For carbon monoxide poisoning, remember carbon monoxide binds to hemoglobin, and that competes with oxygen for the binding sites on hemoglobin. So the treatment is 100% oxygen and hyperbaric oxygen. And then for methanol or ethylene glycol poisoning, the drug of choice is fomepizole, which inhibits alcohol dehydrogenase. Or you could give ethanol, or you can do hemodialysis. Now let's move on to the lecture.
Hi, I'm Dr. Shuford. Welcome to our session on non-staining and poorly staining bacteria. Let's jump right in with Gardnerella vaginalis. Now, Gardnerella vaginalis is a big player in bacterial vaginosis. What's bacterial vaginosis? It's a very common cause of vaginal discharge. What appears to happen is that the bacterial flora of the vagina changes. The lactobacillus numbers decrease and the other bacteria increase, especially gram-negative rods. It's not called bacterial vaginitis because there isn't inflammation or invasion of the vaginal epithelium. It's just really a shift in bacterial flora. But this shift in bacterial flora definitely makes itself known, usually as grayish vaginal discharge with a fishy odor. Now, there's also an associated elevation of vaginal pH to greater than 4.5. And one diagnostic clue to bacterial vaginosis is the clue cell. What's a clue cell? It's actually just a vaginal epithelial cell that's covered with coccobacilli. But there are usually a lot of them in bacterial vaginosis. Risk factors for bacterial vaginosis include new sexual partners or multiple sexual partners. How do we treat this? Usually with a 7-day course of oral metronidazole or with a course of metronidazole cream. Okay, enough about fishy discharge. Let's move on to rickettsia. Rickettsia don't gram stain well, but they can be seen with Giemsa stain. Now, we mentioned rickettsial infections in another session, but we're going to review them again here. Remember that these illnesses are characterized by the rickettsial triad: headache, fever, and rash. This is especially true on tests. In real life, that rash can be hit or miss, but the fever and the headache are major clues to this diagnosis. These patients are suffering with headache and fever. The other thing that you must pop into your brain when you think of rickettsial illness is doxycycline. Doxycycline is the miracle pathway to get these people feeling human again. Now let's talk about a few rickettsial illnesses, starting with Rickettsia rickettsiae. Rocky Mountain spotted fever is what's caused by Rickettsia rickettsiae. This is transmitted by ticks. What are the symptoms? Rocky Mountain spotted fever has fever, headache, and rash, like the other rickettsial illnesses that we're talking to you about. But there is one thing I really want you to remember about Rocky Mountain spotted fever: rash on the palms and the soles. If you take a look at this image, you can see the rash. It usually starts on the wrists and ankles and moves to the palms, soles, and trunk. What other things cause rash on the palms and soles? So Kawasaki disease, Coxsackie A, Rocky Mountain spotted fever, and secondary syphilis. Now, Neisseria meningitidis could also be included on this list, as meningococcemia can certainly cause a palmar rash, but is less common than these other causes that are seen in the Kawasaki CARS mnemonic. Okay, back to Rocky Mountain spotted fever. This infection is found in every state in the United States, utilizing different ticks in different regions, but it always has a tick vector. What about some of our other rickettsial diseases? Let's start with epidemic typhus. Remember that we're talking about Rickettsia prausechii here. How is Rickettsia prausechii spread? Through lice, head and body lice. Remember that we said that prausechii, that long I, sounds like the long I in lice. Epidemic typhus has the same triad of headache, fever, and rash, but the rash starts centrally and then travels to the extremities, but it still spares the palms and the soles. You're not going to see it there. Now, endemic typhus, which is also called murine typhus, is caused by Rickettsia typhi. Remember that we said that E sound in typhi sounds like the long E sound in fleas. Rickettsia typhi is spread by fleas. Again, this is associated with that triad of headache, fever, and rash, where the rash starts centrally and then it spreads peripherally, but it spares the palms and the soles. Okay, now on to our next poorly staining bacterium, and that's Ehrlichia. Now, Ehrlichia chaffiensis causes human monocytic ehrlichiosis, or HME, and Anaplasma phagocytophilum causes human granulocytic anaplasmosis, or HGA. Now, just a few years ago, these were both called Ehrlichia because they're very similar organisms with usually indistinguishable clinical syndromes. They present with an acute febrile syndrome with nonspecific symptoms like headache, myalgias, chills. There can be some impressive lab abnormalities, but it's really hard to differentiate from some other illnesses, and it's hard to get a good diagnosis on this one as well. Culturing these organisms is nearly impossible. So one way to diagnose these infections is by looking for morulae, or inclusions within the monocytes or the granulocytes. These two organisms are both spread by tick vectors. Ehrlichia chaffiensis is usually spread by Lone Star tick, whereas Anaplasma is usually spread by Ixodes scapularis. Now, where have we heard about Ixodes scapularis before? Do you remember? Remember that this is the vector for Lyme. So this can get all confusing when someone living in Lyme territory is bitten by a tick and then ends up with a febrile illness. And actually, co-infection is not uncommon. The good news is that this whole situation can be cured with doxycycline. It is what we use to treat Lyme, and it is the treatment of choice for anaplasmosis. Doxycycline is the ticket here, and what would we do without doxy? Okay, let's move along to Q fever. The Q is for query, like, wonder what's going on with this patient. Q fever is a little bit strange. It's caused by Coxiella burnetii, which used to be considered a rickettsial organism, but it's not considered that anymore. But like rickettsia, it's a small bacillus that doesn't stain well or culture well. One interesting thing about Coxiella burnetii is that it can go through a sporulation-like process that protects the organism and allows it to survive for a long time in the external environment. The primary sources of human Q fever are farm animals, like sheep and cattle. It can be spread through aerosols from urine and feces. So working on a farm or even living downwind from a farm is a risk factor for Q fever. The placenta from an infected organism, from an infected animal, is going to have a very, very high burden of organisms. So birthing farm animals is actually a really big risk factor. Drinking unpasteurized milk is another risk factor. Now, we talked about another organism being spread through unpasteurized milk. Do you remember what that one was? We talked about Brucella doing that as well. Now, Q fever presents as an acute flu-like illness, often with pneumonia, but then it can become a chronic illness that can be associated with endocarditis. Okay, now let's move on to chlamydia. Chlamydia trachomatis is a small intracellular rod-shaped organism that stains and cultures poorly, like everything else we've been talking about. Now, there are different serotypes of Chlamydia trachomatis. Serotypes A through C cause trachoma, which is an acute eye infection that's mostly seen in resource-limited regions. The acute infection can lead to chronic scarring of the eyelid and to chronic corneal damage and eventually to blindness. Now, serotypes D through K are responsible for the sexually transmitted disease that we call chlamydia. The most common clinical manifestations in adults include urethritis, cervicitis, and pelvic inflammatory disease. And it's actually the most common bacterial cause of cervicitis. And unfortunately, it doesn't just stay in the lower reproductive tract. Chlamydia can easily ascend through the reproductive tract and cause scarring in the fallopian tube. The scarring there, as well as the destruction of the cilia within those tubes, place these infected women at very high risk of tubal infertility and ectopic pregnancy. And chlamydia is a major cause of infertility around the world, unfortunately. One major problem with chlamydia is that infection in adults is subclinical in about 50 to 80% of people. They don't even recognize any symptoms of being infected, so they can't seek out treatment. The chlamydia is left to just silently progress and slowly destroy the reproductive system. And that's why we recommend screening for chlamydia. Treatment of uncomplicated chlamydia is fairly easy. It's a one-time dose of azithromycin. Really, the trick here is making that initial diagnosis. Chlamydia can also infect babies who are born to infected mothers, resulting in a conjunctivitis and a pneumonia in newborns. So the topical ointment that prophylactically given to most infants at birth can treat gonorrhea conjunctivitis, but it's not effective at treating chlamydia trachomatis conjunctivitis, and this needs to be treated with oral erythromycin or azithromycin. And lastly, serovars L1, L2, and L3 cause lymphogranuloma venereum. And this is a sexually transmitted infection too, but it presents with a genital ulcer followed by unilateral lymphadenopathy. The lymph nodes can present like buboes, and then they go on to rupture, and this is where you see the groove sign. These same serovars, L1, L2, and L3, can also cause a very painful proctitis, which can be confused with inflammatory bowel disease, like ulcerative colitis or Crohn's disease. Now, don't confuse lymphogranuloma venereum with granuloma inguinale, which is caused by Klebsiella granulomatis and causes granulomas rather than that lymphadenitis. Another thing to remember about chlamydia trachomatis is that it's associated with reactive arthritis. Do you remember what other bacteria are associated with reactive arthritis that we've already mentioned in previous sessions? Well, diarrhea bugs are commonly associated with reactive arthritis, like Campylobacter, Yersinia, Shigella, and Salmonella. Okay, now let's move on to a couple of Chlamydophila species. These were formerly included in chlamydia species, but now are called Chlamydophila. The two that I'm going to highlight here both cause pneumonia. The first one is Chlamydophilus psittaci, and this one is unusual because it's spread from a bird. It causes a pneumonia syndrome called psittacosis. Many bird species can actually serve as reservoirs for this bacteria, but test questions are usually going to include a statement about having a pet parrot at home. The other Chlamydophila species that we're going to mention here is Chlamydophila pneumoniae. Chlamydophila pneumoniae is a major cause of atypical pneumonia. The three primary etiologies of atypical pneumonia include Legionella pneumophila, Chlamydophila pneumoniae, and the one that we haven't talked about yet, Mycoplasma pneumoniae. Chlamydophila pneumoniae can cause a prolonged mild pneumonia, commonly called walking pneumonia. When it's diagnosed as Chlamydophila pneumoniae, the treatment of choice is doxycycline. But if no microbiological diagnosis is made, then the empiric treatment for atypical pneumonia is usually azithromycin, and it does work. Okay, let's finish up this session with Mycoplasma pneumoniae. This is a 4-star topic, so listen up while we talk about this one. Why is Mycoplasma one of the poorly staining bacteria that we're talking about today? Well, Mycoplasma species don't have a cell wall, so they're not able to be seen with gram stain at all. It's spread person to person through respiratory droplets. Mycoplasma is a very common cause of pneumonia in school-aged kids, in college students, and in military recruits. This is very similar to what we said about meningococcal meningitis. Now, test questions about Mycoplasma or Neisseria meningitidis frequently include a patient who's a college student, so look for that clue. Now, the first symptoms of Mycoplasma pneumoniae include malaise, headache, and low-grade fever, followed by a non-productive cough and diffuse interstitial infiltrates. This isn't the same picture that we see with typical pneumococcal pneumonia, where there's a really ill-looking patient, possibly looking a little septic, with a productive cough and a lobar infiltrate on chest x-ray. This is another of those walking pneumonias where a young person has been coughing for weeks and says that his head hurts terribly every time he coughs, but that he's actually making it through classes and doing okay. Now, chest x-ray will usually show patchy or reticulonodular infiltrates. So how do we diagnose this one? Well, actually, we don't often go after a specific microbiological diagnosis because empiric treatment for atypical pneumonia is usually successful when you use a macrolide like azithromycin or doxycycline, and fluoroquinolones can also be used. But if you are searching for a microbiological diagnosis, there are a few tests that you can use. And the one I want you to remember for the test is cold agglutinins. What are cold agglutinins? They are nonspecific IgM antibodies to erythrocytes that can occur early in this mycoplasma illness. They can agglutinate or lyse red blood cells in cold environments, and that's why they're called cold agglutinins. Now, this response is nonspecific, though. Diagnosis can be made more definitively using either serology or PCR. Before we get to the end-of-session quiz, let's take a minute and do an exercise. There is a list of some buzzwords and descriptions on the left, and I want you to match it with the associated organism or condition on the right. So take a minute and jot down the answers, and then we'll go through them. Clue cells, fishy discharge, change in bacterial flora, that's Gardnerella vaginalis. Rash on the palms and soles, spread by ticks. Fever, headache. That's Rocky Mountain spotted fever. Central rash and spreads outward, spread by fleas, fever, headache. That's Rickettsia typhi. Urethritis, ectopic pregnancy, infertility. That's chlamydia trachomatis. College student, prolonged cough, reticulonodular infiltrate. That's Mycoplasma pneumoniae. Exposure to sheep placenta, fever and pneumonia, endocarditis. That's Q fever, caused by Coxiella burnettii. And now let's go to our end of session quiz on non-staining bacteria. So go ahead, turn off your video, do the end of session quiz questions, and then start that video back up again so we can go through those answers together. All right, let's go through the answers to your end of session quiz. The first question, what is the rickettsial triad of symptoms? Remember, headache, fever, and rash. Really important, headache, fever, and rash. Next, a 25-year-old with Mycoplasma atypical pneumonia exhibits anemia due to cold agglutinins. What type of immunoglobulin is responsible for the anemia? Remember that cold agglutinins or cryoagglutinins are typically IgM antibodies. And lastly, what antibiotic should be used to treat each of the following infections? From Mycoplasma pneumoniae, just like with chlamydia infections, you're going to use doxycycline or a macrolide like erythromycin or azithromycin. For Rocky Mountain spotted fever, doxycycline. And bacterial vaginosis, it's treated with metronidazole. And that's the end of our end of session quiz, and that's the end of our lecture on non-staining bacteria. I'll see you next time.
Chlamydophila pneumoniae causes atypical pneumonia, which is symptomatically less typical than typical pneumonia. Atypical pneumonia is sometimes called walking pneumonia, although you don't catch it from walking, but you can have it while walking. You don't catch psittacosis from sitting down. You catch it from birds, like parrots and parakeets. Psittacosis is a lung infection caused by Chlamydophila psittaci. Symptoms include fever, headache, and cough. The bird might be asymptomatic. Also, birds can't technically cough. Look it up.